Thanks everyone for waiting. As you can see, I promised you that Dr. Tsakos will be back, and he's right here with us. So I'm glad that you are here and you can hear me. So I hope you have had a great day and are ready to inspire our patients.
Yes, I am. Hi, good evening, everyone.
Thank you so much for joining us tonight. And thank you, Dr. Tsakos, for your speech tonight. I'm sure it's going to be interesting for the patient and useful. And let me just remind everyone that we will start with the speech and we will talk about the number of cycles needed for a successful pregnancy, of course. And then we will have your questions. Dr. Tsakos will definitely answer them for you. So prepare them right now, or you can put those in the chat section later on. And I also want to mention that, as you know, my IVF Answers, we are a part of European Fertility Society, and we are here to simply support you, give you some answers, but also educate you in any way we can, because we simply want to make sure that you are going to do and make informed decision when choosing a clinic or when choosing a doctor, or just the whole idea of how everything works as well. And let me just mention Dr. Tsakos. If you don't know already, he's a medical doctor at Embryoclinic located in Thessaloniki. And Dr. Tsakos has been with us many, many times before. And I'm very happy that we are able to give you another interesting topic and, of course, another interesting webinar, no doubt. And that is it from me. Thank you for staying in with us tonight, of course. And Dr. Tsakos, are you ready to begin?
Yes, I am. Thank you.
Glad to hear this then, and let's go ahead.
Hi, good evening, everyone. Hello, Caroline. Hello to all the people listening to us this morning. Sorry about the small connection problems we had, but we seem to be ready to go. Now, straight into the subject. How many IVFs for a successful pregnancy? And very clear answer, depends. Depends on the individual case, depends on the individual couple, depends on how you set up before you start your possible successful outcome. So the first thing I do with my patients is try to define what is a successful outcome and try to investigate all the individual circumstances in order to set out the possible number of treatment cycles necessary. And of course, in order to design that, I would have to work individually with every couple and take into account their history and their particular circumstances. So in order to be more specific, before we start one IVF cycle, it's very important to define what are the chances of this particular couple, depending on their individual case. So, for example, if we have a young couple in the early 30s, with maybe tubal factor, or with maybe a small male factor infertility, or even with unexplained infertility. So in early 30s, who haven't done IVF before. So we're talking about a success rate per embryo transfer in the region of maybe 40 to 50%. So statistically, this couple, within a couple of embryo transfers, they could be successful. And of course, with one stimulation cycle, we can more or less ensure 2 or 3 possible embryo transfers if a couple are in the early 30s and if the female has a normal ovarian reserve. So maximum 2 or 3 embryo transfers would suffice for achieving a successful pregnancy in a couple in the early 30s who haven't tried before. But of course, things may be complicated if this couple have been unsuccessful before. The more failures a couple has, regardless of their age, maybe the less chance of success there is, regardless of whether they change units or not. So in my opinion, this is a very important factor. Before I go on to giving you a different example, I would like to stress on the importance of adequately investigating the couples. I spent this evening with a wonderful colleague of mine who works in units in Spain, and we had this brainstorming about what's necessary and what is considered to be essential investigation for a couple undergoing own eggs IVF. And to my pleasant surprise, we agreed that perhaps checking the karyotype or checking very standard endocrine profiles, including thyroid function and prolactin levels, is part of the essential investigations. Of course, some people would go a little bit further and would include some sort of elaborate tubal assessment or uterine assessment by means of a hysteroscopy as part of their baseline investigation. Now, I can see some people waving from Germany, from Cameroon, from Austria, from England, from Greece. And what I have to declare here is that, unfortunately, there's no agreement between us doctors all over the world. There's not even agreement sometimes between doctors within the same unit as to what consists of baseline investigation. But the message I would like to pass on with my 30 plus years of experience, and sometimes I find myself being very graphic by describing how I used to be in my first decade as a fertility doctor, how I became in the second decade, and how maybe I have evolved in my third decade. And I have seen by looking back that even individual doctors like myself, like other wonderful colleagues all over the world, we have changed our approach over the last 10 or 20 years. And we have changed the way we investigate our patients and the way we consider what is essential investigation and what's not. I mean, 30 years ago, because scan machines were not as technologically advanced as they are today, we used to perform more laparoscopies than we do now. And perhaps in many cases, we were right in doing this. As a general thought and as a general impression of mine is that, unfortunately, we tend to investigate less and less. And of course, the level of investigation performed depends vastly on whether it's a public-funded IVF cycle, whether this is in England or in Germany or in Serbia. In general, public sponsored cycles are not thoroughly investigated, perhaps because the fund holders have decided that it's best if they offer more IVFs than more elaborate investigations. So there is a huge range and a huge difference in the level of investigating couples. So I described what is successful outcome in the early 30s. So if we have a couple in the mid 30s, maybe 35, 37-year-old female with more or less the same age or slightly older or younger male partner, then the success rate drops, of course, with IVF. And again, I'm speaking general now. So with standard ovarian reserve couples in the mid to late 30s, they would have a less chance of success with their own eggs. So we're talking about an average chance of maybe 35 to 40% per embryo transfer. And in those couples, again, we would probably need on average 2 or 3 embryo transfers in order to achieve the successful outcome. Of course, this changes dramatically when the female age is very near the age of 40. Even normal, I mean, I have 40-year-old women coming to my clinic devastated because their AMH levels are low, only to find that after, of course, I explained to them that what is a low AMH level at 40 is totally different to what is normal or low AMH level at the age of 35. And of course, it is normal for a female in the 40s to have an AMH level around about 1 nanogram per ml or 4 picomoles per liter. So it is normal for the AMH to be low at that age. And of course, success rate of IVF drops dramatically at 40. And we're talking about maybe success rate in the region of maximum 20% per embryo transfer. And of course, in those cases, we may need 3, 4, or even 5 embryo transfers to achieve the successful outcome. And of course, when we're going beyond the age of 40, when we're in early 40s for the female, then the success rate drops even more. And in those patients, we may need 5 or 6 embryo transfers if we want to be on the secure area of achieving a pregnancy. Now, all this sounds very simplified, and of course it is, because most couples, apart from the age factor, they also have other additional factors for infertility. And in my opinion, as I mentioned before, an additional factor is previous failure or previous diagnosed pathology related with infertility in the likes of endometriosis, polycystic ovaries, pelvic inflammatory disease, multiple IVF failures, miscarriages, male factor infertility, and so forth. So in those cases, they may need more IVF attempts in order to achieve a pregnancy. Now, I think sitting with the patients is very important. I tend to address them as my team, and I tend to like for myself the term coach of the team. And of course, we don't pick our teams. I mean, the teams pick the coaches. So as a coach, my team and I, we like to work together, and we like to improve the odds by improving factors that can be improved. Of course, if we have a 40-year-old female in a couple, we can't make them younger. However, we can give them the best possible chance by addressing all those factors that influence the success. And I'm talking not just about all the physical factors, but also all the emotional and psychological factors that not only could give them the best possible success, but also improve the experience. Because in my opinion, the worst possible outcome is the dropout of the patient. So it's up to us and it's up to our teams to ensure that we have adequate support and counseling in order to empower our couples to move on after the failure. Of course, we're always focusing on the success, together with the safety, of course. But unfortunately, failure is on the cards, whether somebody is in their early 30s or whether they're in their early or mid 40s. Now, having covered the own egg success, I always like to lay on the table all the other possibilities and all the other options. For example, if we have a couple with a female age of 40 or a single woman in her 40s who has tried 3, 4, 5 implantations in the past with adequately normal embryos, then I would like to offer them something extra. There's no point expecting a different result by repeating the same technique, if you like. So I'm a big fan of thoroughly investigating. I'm a big fan of exploring all the important areas of investigation before I move on, especially in couples with associated failures in the past, either in other units or in our own unit. So I would like to ensure that genetics is sorted out. I would like to ensure that endocrinology factors are sorted out. I would like to ensure that all the protocols, stimulation protocols are correct. I would like to ensure that egg collection, embryo transfer is done perfectly. And of course, I would like to ensure that the lab is working very well based on the key performance indexes from our labs. Now, there is a moment in time where probably the possibility of success associated with the couples or the patients or even single females using their own materials comes to the end. So if a female with or without a partner with her own genetic material in her early 40s has tried 3, 4, 5 times with own eggs IVF, if she has explored all the genetics, all the immunology, all the anatomy assessments, and everything seems to be optimized and there has been failure, then maybe we have the last resort of PGTA testing the embryos. Because as we probably all know, when we see a healthy embryo under the microscope, it doesn't necessarily mean that this is a genetically intact embryo. So PGT testing of the embryos is giving us this extra confidence that at least we're transferring euploid, as we call them scientifically, or normal, genetically normal embryos into the uterus. So that would be a step further to ensure that we give our couples the maximum possible chance. And when this has been explored, of course, we need to thoroughly investigate the male partner. Males are generally less complicated than females in terms of their genetics. So a male with normal or fairly normal sperm count, or a sperm count which is reasonably normal for us to utilize micro injection, ICSI technique. Perhaps we can further investigate by means of genetics, by DNA fragmentation, by ensuring that the endocrinology profile of the male is also normal, and more or less, of course, by checking that the embryos are capable of producing healthy blastocysts. And if we genetically test those embryos, and if they're still normal, we can be fairly confident that the male side of the equation is normal before moving on. Now, there's always a moment in time where we start thinking about using donation or donated gametes. Usually this refers to egg donation, especially with females of advanced reproductive age with repeated implantation failures, repeated IVF failures, or miscarriages, who have explored thoroughly the route of own IVF, own eggs IVF. In my opinion, after 4, 5, 6 embryo transfers of embryos in a female of the early 40s or mid 40s or late 40s, I think this is probably the time when we need to move on to the possibility of egg donation. Of course, this is not an easy decision. This is a decision that has to be made together with the couple and the treating doctors, nurses, scientists, embryologists, counselors, and so forth. It's a very difficult decision. I think it's a huge crossroad that the couple have to move on together, having been empowered by the knowledge and the psychological support. And if they do, then the tables are turned. So, when we have multiple failures with own eggs, IVF in late 30s, early 40s, mid 40s, late 40s, then by using egg donation, we can be confident that we can be looking into a success rate, a cumulative success rate per embryo donation, egg donation cycle of more than 90%, which means that 9 out of 10 of our couples, after 1, 2, or maximum 3 embryo transfers of an embryo created by using an egg donor, a young egg donor, and the healthy sperm of the partner, if there is a partner with healthy sperm there, or fairly healthy sperm, 9 out of 10 of our couples will achieve a pregnancy. Of course, there's the small portion of that population, less than 10% in my experience and in our hands, that would still fail. We still fail. I mean, let's all remember that IVF can never be 100%, unfortunately. Whether we use own eggs, egg donation, embryo donation, 100% has not been achieved, will never be achieved worldwide. However, more than 90% is something that we can fairly confidently achieve. Now, what happens if we're not there? What happens if we use egg donation and there's still unsuccessful 2 or 3 efforts? Then again, we open the cards again, we review the whole file again, ensure that all investigations have been made, ensure that the anatomy, I'm a big fan of female anatomy workup. I mean, today I had a wonderful patient from the Balkans who came for IVF after so many failures, and we just discovered that she has a unicornuate uterus. I mean, a unicornuate uterus is half a uterus. Essentially, the other half has been absorbed during fetal life. However, a unicornuate uterus can be fairly big and can very easily escape the diagnosis if we haven't been 100% accurate and careful. How do we confirm the diagnosis? Simply by means of an HSG, and of course, then we need to double this with a hysteroscopy, sometimes with an MRI and a laparoscopy. And of course, the big decision is to decide whether that uterus would be suitable or would be possible to carry a healthy pregnancy to term or to near term or not. Although it sounds weird, it happens. It has happened to me over my 30 plus years in this field, to have women with unicornate uterus who have been treated with IVF unsuccessfully, and that hasn't been diagnosed on time. I've had women with didelphys, uterus didelphys, or huge women with diaphragm in the uterus dividing the cavity into two that has been missed, and so forth. So in my opinion, and as a doctor, but also you yourselves as patients, always question whether you have been fully investigated, and always ensure that you challenge us whether at least the basic important investigations have been made before you move on to any important next step. So after the egg donation, we have the embryo donation. We resort to embryo donation if there has been failures with egg donation and own sperm. And in particular, this is associated with bad quality sperm that we probably know beforehand. Unfortunately, the same way women age, men age as well, perhaps a little bit later. In terms of genetics, but it is commonplace to have men attending the clinic in their late 40s, early 50s, late 50s, mid 60s, and in that population, it is commoner. It's very common to have abnormal sperm parameters, and of course, abnormal sperm produces sometimes abnormal embryos. That may or may not be obvious under the microscope, not even sometimes after PGT-A testing those embryos. And in those cases, after many unsuccessful attempts, then maybe embryo donation might be an option for those couples to move forward. When we use the donated embryos, as doctors and scientists, we ensure that at least the embryo is of top quality, because it's a donated embryo, sometimes it's a tested embryo. So at least those factors contributing into the embryo have been fully scrutinized, and we're very happy with the quality. And in that case, of course, we focus on the quality of the recipient, on the anatomy of the female patient receiving the embryos. But let's not forget that the anatomy, part of the anatomy of the uterus is also the tubes, is also the peritoneum, is also the area surrounding the tubes, and of course the environment, which consists of the blood supply to the uterus, of the microbiome of the uterus, of immunological factors of the female, endocrinology factors of the female, and so forth. But when we use embryo donation, again, we work in the area of more than 90% overall success rate after a couple of embryo transfers. We insist on single embryo transfer, of course, on the embryo transfer of one top quality embryo. And the vast majority of those patients will be successful. So having exhausted own eggs IVF, egg donation IVF, embryo donation IVF, the vast majority, perhaps 95% of our couples, if not more, will achieve a pregnancy with a maximum of 3 to 5 embryo transfers altogether. The big question is what happened next, and the answer is that there's still a solution, and this is what I quote to my patients when I ask them, how much do you want to be parents? And when they say very much, my next question would be, how far would you prepare to go? And if the couples or single women are prepared to go all the way, then all the way involves surrogacy as well, gestational surrogacy, in which case we can have parenthood with or without the use of genetics of the parents or of the single mother, and of course with the use of a gestational surrogate who would carry either a genetically produced child from the intended parents, or a totally genetically different child from a third donor or from third donors. So we can have own eggs surrogacy, we can have egg donation surrogacy, we can have embryo donation surrogacy. And the overall success rate of this program is as near 100% as anything can be in medicine. So take-home message is that as long as the couples understand their odds, as long as the couples understand, or the single women for that matter, understand that there is a specific percentage of success related to the type of IVF we perform for each one of them, and as long as they understand that we know what to expect from every treatment, we know how far we have to go for each treatment, and we know when to move on to the next treatment, and as long as they are prepared to accept those options, I would probably quote that more than 95% of the couples or the single women will eventually achieve a pregnancy within maximum 3 to 5 embryo transfers overall. So thank you very much for listening. I'm ready to be challenged by each one of you. Thank you, Caroline, for hosting this. So I'm ready for questions.
Brilliant as always. Thank you so much indeed for a great speech here, and of course encouraging everyone. And I'm sure it's going to be an interesting session. I already see so many questions, so thanks everyone for all the questions and for listening. And let's start with the first question, okay, right here. So what are the COVID rules for patients who want to come to you from abroad? Do you have to be vaccinated? How does it look like today?
Hi. Well, thank you for the question. I mean, as you know, the COVID rules change every 2 to 3 months in every country. So at the moment in Greece, no, you don't have to be vaccinated. You can attend without having been vaccinated. We see appointments. Of course, we keep all the COVID safety rules in order to protect patients and staff alike. So anyone can attend the clinic, whether they're vaccinated or not, of course, with very, very strict rules and safety issues. And actually, Embryoclinic is one of the very few clinics, at least in Europe, as far as I am aware, that we are COVID. We have a COVID safety ISO. We call it COVID Shield. So we have very robust safety guidelines in place. So you don't have to be vaccinated. Having said that, when you do start your IVF, you would have to be tested negative with PCR twice for the female and once for the male just before giving sperm.
All right, thanks so much for the first question and for the assistance here, Dr. Tsakos. That sounds good. And of course, there are plenty of questions coming in. Lots of you are adding more. So let me just go to the next one here from Jorge. What about patients only with only one ovary and poor response that get just one embryo for transfer and do not want egg donation?
Absolutely, I would keep going. I mean, how old are you? Okay, until you type your age, what I would say is that as long as patients produce at least one embryo, we can keep going. And the good news here is that if there is a poor response with one embryo, with one egg, or with 1 or 2 follicles, we don't even need to do any major stimulation. So doing natural cycles can be very successful, or using mild stimulation cycles, either with the use of Clomid or letrozole, plus or minus a small dose of FSH, could successfully give us 1 or 2 follicles and 1 embryo. So anyone with a reasonable age, and reasonable age for own eggs for me is under 45, who is willing to keep going with this program And as long as they produce an embryo, I would just keep going, keep doing implantations. I mean, of course, again, depending on the age and depending on how many unsuccessful implantations they've had so far, there's always the option of PGTA testing the embryo or the embryos to ensure that at least we transfer a healthy embryo. Let me make one thing clear here. Egg donation is not compulsory, is not obligatory, and to be honest, it's not that widely available. I mean, there is a misconception about egg donation. I mean, what I would like to mention, at least for our practice and perhaps for my country, is that the patients, they understand when they need egg donation, and they ask for it when they're ready for it, when they're ready psychologically, when they're ready physically, and when they understand they have explored fully the chance of using their own material. And the same applies with clinics. I mean, specifically speaking about our practice and our clinic, I mean, we would always mention that egg donation may be an option for somebody who with multiple own egg IVF failures, especially if they're in the early 40s. So we would always mention that as an option. But as long as someone is producing eggs and it is safe to proceed with egg collections and embryo transfers, we would definitely like to explore that fully before resorting to egg donation.
Okay, thank you so much. And of course, if you have any follow-ups, go ahead, type this in, okay? And let's go to the next question. Is it true that embryo itself plays the most crucial role, 80%, and all other factors account for the rest, 15, 20%?
To be honest, it is important. The embryo is important. I'm not sure about the figures. I mean, I have seen some figures similar to that. So, but I'm not sure where they came from. So, yes, it's very important to have a healthy embryo. So, embryo is very important. On the other hand, if you have an unfriendly endometrium, I mean, I had a case actually today. I had a request from a patient in her late 40s who'd had 20 years of infertility, who'd had 10 or 12 IVF failures, who's had own egg failures, who's had laparoscopies, hysteroscopies, ectopic pregnancies, pelvic infections, multiple IVF failures, including embryo donation IVF failures. I mean, that patient is clearly for surrogacy. So, yes, the embryo is important, but let's not forget the endometrium. Let's not forget the recipient, the health of the female. And the health of the female, yes, of course, a big component is the uterus, is the endometrium, but also there's other factors. I mean, there's women in their late 40s who are fit as a fiddle, and there are women in their late 30s who are seriously overweight, with diabetes, with adenomyosis, with scarring in their uterus, with operated on uterus, with fibroids and so forth. So I wouldn't like to put figures. I don't think figures are that important in that, but I think it is important to be clear about the value of a good embryo. That's why we need to ensure that we have top quality embryos. We need to ensure that we only transfer top quality embryos. That if we're unsure about the embryos, it's better to either wait until we become more sure, more certain, or we don't even transfer. I mean, it's not nice to transfer embryos of bad quality, and I think every clinic have their own standards. And thankfully, most clinics don't transfer embryos that are not of good quality. So I think it's very, very important to understand that every single factor is important. It's like building a house. You have to have very good foundations. You have to have nice location. You have to use good products and so forth. And the same applies with IVF.
Thanks so much. Actually, there's a follow-up. Let me go straight to that one, okay? So what do you mean by a healthy endometrium hysteroscopy, not sure, check for endometritis and lactobacillus?
Sure. Okay, thank you so much. I mean, thank you, Olga. Um, Basically, you can never be 100% about 100% health of the endometrium. But in my opinion, the minimum level of investigation of the endometrium includes a very good quality scan, ultrasound scan performed by somebody who is an expert in vaginal scanning and with using very high-tech equipment. And that has to be coupled with some sort of hysterosalpingogram test, whether it's X-ray or hyphosi. Perhaps that's a big question, but not just a scan. So some sort of imaging of the uterus and the tubes and the endometrium. And always keep in mind that a hysteroscopy, in my opinion, hysteroscopy is part of the baseline essential assessment of the endometrium in the majority of cases. So for me, these three are the absolute minimum. Of course, if there's multiple failures, or if there's any worries, or if there's any abnormal findings, then again, taking a biopsy of the endometrium to check for histology and microbiome may also play a role. And since we're still in March and it's still the endometriosis month, let's not forget endometriosis, guys. I mean, endometriosis is very, very common, especially in infertile patients. Let's not forget that. We tend to, I mean, the more we have advanced, there's the scientific fertility community, the more we have advanced the IVF technology and science, the more we have forgotten the importance of endometriosis and the fact that endometriosis may only be diagnosed by laparoscopy. Of course, we don't want to do laparoscopies. Of course, our patients don't want to have laparoscopies done. But let's not forget the endometriosis factor-associated inflammation and infertility and IVF failure.
Thanks so much for the follow-up here as well and your help with that. Now we will have some more details. Okay, so let's have a look at this longer question. So here it is. Me and my husband have no problem making euploid embryos. In 2.5 years of trying, followed by 7 euploid transfers, I have not had a single positive pregnancy test. After exhausting all evidence-based investigations, autoimmune screen, thrombophilia screen, HSG, hysteroscopy, ERA, EMA, ALICE, karyotyping, we just had immune testing. I have high NK cells and complete DQ alpha match with my husband. I have been advised to try LIT and then a transfer cycle with steroids and intralipids. Realistically, what is the chance that I will get a positive test followed by a birth?
Very difficult to. I mean, how old are you? I mean, that's I think a big question.
If you can add this, 36. 36.
I mean, the second question is, I mean, what embryos are you using? Are you using day 3 embryos? Are you using blastocysts?
Day 5 blastocysts.
Day 5. Okay, I would keep going. I mean, I know it sounds like a long shot, but you're still young. You have high quality euploid blastocysts. You seem to have done all the nice things, all the good things. I would consider laparoscopy in your case, to be honest, if I want to give you a straight possibility, a laparoscopy, to exclude endometriosis that is not visible on scans or on other tests, to ensure that you don't have any inflammation factors in your tubes or in your pelvis. And I would get the most senior person in the unit to do the embryo transfer. You know, let's not forget that embryo transfer is like shooting a penalty. You know, you have the whole team working for 90 minutes, and then somebody has to hit the penalty and somebody has to score. And, you know, for all those football fans, I'm not a football fan, I'm a basketball fan, but I always get all the butterflies when I see people failing to succeed in a penalty shot. And why? Because there's a lot of stress. We've all seen amazing players missing a penalty. So for me, the embryo transfer is a penalty. Why? Because it's easy, because it will give us the success or failure, but it has to get there. It has to be perfect. And the more I look around and the more I discuss with my colleagues all over the world, I understand that there's a huge variation of the embryo transfer technique. And again, I could challenge, and I could be challenged forever about the embryo transfer technique. I have changed my embryo transfer technique so many times over the last 30 years. I think now that most of us agree that there's perhaps a standard embryo transfer technique, which includes ultrasound guided embryo transfer. But again, there's so many secrets there. What catheter we use, what kind of scan we use, is it an abdominal scan that most of us use, or still some people use vaginal scan? What kind of catheter we use? Have we done a hysteroscopy a couple of months or 2 to 3 months before the embryo transfer to ensure normality and the normal fairly easy and not stenosed cervix and all that? So unfortunately, even after 7 embryo transfers, there's still some areas that may go wrong. So I would probably suggest a laparoscopy on you to ensure that the pelvic area is normal. I would definitely use all that stuff. I mean, I'm not a huge fan of interlipids, but probably they don't do any harm. I would definitely use steroids, possibly aspirin, and possibly low molecular weight heparin to ensure that at least I have covered empirically all the areas that may affect. I would very carefully monitor the progesterone levels. I would be very pedantic. I would be very careful in monitoring the frozen embryo transfer cycle. Again, there's huge variation on how people manage the embryo transfer cycles. I would get some feedback. I would get perhaps second opinions on how to do that. Natural embryo transfer, frozen embryo transfer, medicated, with downregulation, without downregulation. There's so many variables that after having had that experience, I would like to be absolutely sure that they're done perfectly. But definitely, I would ask kindly the most experienced person in the unit to be personally in charge and perform things as perfectly as possible. And I would be optimistic. I think you will make it.
Thank you so much for your advice, and best of luck, of course. And remember that if you wish to get some more details, there is a way for you to get in touch with Dr. Tsakos, his team at Embryoclinic. I'm sure they will be able to help you even more, right? So thanks so much. And of course, let's have a look. More questions are right here. So next one is also ready. I went for hysteroscopy, was told my uterine lining is thin. What can I do so I have a successful pregnancy and implantation?
Okay, this is tricky, Adi. This is difficult and tricky. It depends on how thin is thin. I mean, thin is 7.5, 7.7 millimeters. After adequate estrogen priming, thin is 5 millimeters after priming. And again, endometrium is not just about thickness. It's also about shape. It's also about the way it looks. It's also about in what stage during the cycle. It's also about whether there's adhesions or not in the uterus. So in my opinion, if there is a query and concern about your thin endometrium, there is a risk that this may be associated with adhesions, with scar tissue. Unfortunately, there isn't any magic wand to treat adhesions and Asherman syndrome of the uterus, as we call it. And this is the time when you would probably need to consult your fertility specialist. If your fertility specialist is also a fertility surgery specialist, they would be able to advise you whether that is something that could be treated by hysteroscopy. This is something whether it can be managed by medical treatment, which would achieve an adequate thickness of the endometrium. And in my opinion, the minimum that the endometrium has to go to for a fairly good chance of success is more than 7 millimeters with a fairly normal shape. And if that can be achieved, then there's various protocols that can work towards that direction, medical protocols, and maybe repeated hysteroscopies and hysteroscopic surgery. And if this is the case, then move on to implantation. If that's not the case, or if you're far below 7 millimeters, or you've had lots of failed implantations, then maybe you should start considering surrogacy. Now, of course, it's very common to have, I mean, the uterus mainly consists of two components. One is the wall and the other is the lining. So it is not uncommon to have a very normal wall. And this is what most people refer to as the uterus, looks good. But then the lining can be. They're both important for a successful implantation and a successful pregnancy. But the most important of all is the lining. The lining is more important than the wall. Abnormal wall, which can be either due to previous surgery for fibroids or adenomyosis or cesarean scars or ectopic pregnancies involving the uterus, it is an issue. It is a factor that the chance of a successful IVF and a successful pregnancy are made by some percentage of 20%, 30%, but the most crucial factor is the endometrium.
Brilliant. Thank you so much for yet another advice here. Short question from Amanda. What about a 41-year-old with a 24 AMH level?
Okay, that's probably good news, Amanda. That's probably good news, but that probably means that there is some sort of polycystic ovaries. Personally, I prefer polycystic ovaries at 41 than not. Why? Because I get many eggs. Of course, many of those eggs are not of good quality, but usually we can work with some of them, the good quality ones. So straight answer, 41 with an AMH of 24 is probably associated with polycystic ovaries. If they're not polycystic ovaries, then they probably behave like ones. And this is a potential for a good stimulation and the production of a lot of mature, probably good quality eggs. So in my opinion, it's probably a good factor to move on with your own eggs.
Great. Thank you so much for that question and for a reassurance here. So does ICSI have an impact, positive, negative, on success of embryo transfer?
Okay. Firstly, ICSI has, depends is the answer. Depends. I mean, there's a lot of literature on ICSI. There's a lot of, there's a little bit of controversy about ICSI. There are some reports saying that maybe if the sperm is normal and if the eggs are of good quality, maybe ICSI does not produce better quality embryos than conventional IVF. I'm not sure about that because there's a lot of factors that may affect the quality of fertilization. I mean, in order to have a successful embryo transfer, before you have a successful embryo transfer, you have to have good quality embryos. And in order to have good quality embryos, and after you've had good quality eggs on the egg collection, you need to have a good fertilization. And sometimes we have fertilization surprises. And sometimes we have bad surprises. So I think the big question is how do we differentiate on whether we use ICSI or standard IVF on our patients? And there's a lot of factors that may produce abnormal fertilization even when it's least expected. So, for example, if we have a young female in her early 30s who's having IVF for tubal factor, and if we have a young male in their mid-30s with normal sperm, we would probably use IVF, standard IVF. In that case, I don't think ICSI would make a huge difference. Having said that, in a small proportion of those patients, there may be a hidden sperm factor or a hidden female factor affecting the oocyte quality, and we may have this bad surprise of very poor fertilization. So we collect 10 eggs from a 32-year-old. We have a normal sperm on the day of egg collection, and then out of 10 eggs, we have 2 fertilized. It's not uncommon, but it happens. So in my opinion, I think, we end up using ICSI more and more. In the early days of ICSI, we used it less and less, and we had this cycle, which we called it diagnostic IVF, which meant that, let's do a cycle. Let's do standard IVF. If we have good fertilization, it means that it was a good choice. If we have a bad fertilization, it's okay, we'll do another cycle. I think in 2022, this is not a valid protocol. So what do I do in my practice, and what I would probably suggest to my patients? Firstly, I think it's of paramount importance to clear with our patients that we will do at the lab, what we need to do to give you the best possible success. And that's why in my unit, despite some other voices, we don't really charge extra at all for whatever we do in the lab in order to achieve better results and better fertilization rates and better top quality embryo creation rates. So there's no such thing as IVF, so much money, and plus ICSI, plus assisted hatching, plus blastocyst culture, plus time lapse, plus embryo glue. Okay, so I want to clear that medically, I think definitely in our unit we disconnect all those extras that we can do in the lab from any additional costs to our patients. Why? Because this is giving us the freedom to do whatever is necessary to achieve the best possible embryos for our patients. So in my practice, and I can be challenged on that, and please, you're welcome to do so. If from a mid-30s couple, I collect 10 eggs, and if I have a perfect sperm, maybe I will do 5 IVF and 5 ICSI. And by doing this, I don't risk having very low fertilization rate for an unknown factor that would influence the conventional IVF success rate. And again, the older the female, the more I would use ICSI, and the older the male, the more ICSI I would use versus conventional IVF, to be honest. And then you have the frozen sperm that we use quite often for various reasons, in which case I would use ICSI and not IVF. So to cut the long story short, ICSI is giving us more standardized fertilization results and rates than conventional IVF, and at least it's securing some good fertilization rates for our patients for either the majority of their eggs, if not all of their eggs. So in my opinion, I think ICSI, whether we want it or not, whether some people consider it interventional or not, I think it's becoming the norm for the majority of our patients nowadays.
Thank you, Fran, for your question and your thorough answer, as always, Dr. Tsakos. Vicky has another question. Using sperm donor as a single woman, 4 failed transfers, 1 embryo left, have been advised to do endoscratch. Is this effective? I'm just turned 40.
Sure. To be honest, okay, this is a little bit disappointing. After 4 failed embryo transfers, I would probably suggest a hysteroscopy as soon as possible, and pretty close to the embryo transfer time, not just a scratch, a hysteroscopy and a scratch maybe. And then the embryo transfer by the most experienced person, and the full luteal support for afterwards. So, good doses of progesterone, adequate estrogen, and maybe empirical aspirin, steroids, and low molecular weight heparin, just to cover all the other possible areas of failure.
Thank you so much for that as well. And let's have a look. We will be slowly finishing, but of course, remember that if we won't be able to answer all of the questions, we will forward those to the team at Embryoclinic, and they will help you out, of course, as well, with Dr. Tsakos here. So let's have a look. Here, Amanda has another question. Does multiple IVF cycles have a cumulative negative impact on the woman's health, and on how many healthy embryos she could create? Could the process mean quality decreases?
Well, very difficult questions to be answered, but I mean, I wouldn't go indefinitely for embryo transfers. And as I mentioned in my small lecture, I would not use the same recipe if I found that this is unsuccessful, even if I cannot explain the failure. And of course, IVF is a wonderful opportunity for a thorough checkup, for a thorough female checkup. We insist on thorough checkup, cervical screening, breast screening, a formal breast screening by means of either a breast ultrasound scan or a mammography. Even that's not part of the guidelines in many countries offered under the public health guidelines. And I don't think that the quality falls with the number of IVFs we perform. The quality the quality is hugely related to the age. So say if we do 2 or 3 IVF cycles within the same year, I don't think the quality is affected by the IVF cycles. However, if we do 1 IVF cycle this year and 1 next year and 1 third year ahead of us, the later we do it, the quality perhaps will be a little bit less, but that's related to the female age.
Understood. Okay, perfect. Thanks so much. Okay, do we still have time for one more question, Dr. Tsakos?
One last one, please.
Okay, not a problem. It's going to be a bit of a longer question though, okay? Sorry. So let's have a look. Some details here. 40, sorry?
Yeah, okay, I can see it. Yeah.
Yeah, 48, 4 cycles with Doesxc. The first one was biochemical pregnancy, second one negative. The third cycle with a new donor was negative. The fourth ended in a positive pregnancy, which ended in a miscarriage on the 7th week. My husband has a bad low spermiogram. We did many diagnostics, including hysteroscopy, endometrium biopsy, genetic testing. It came out of the MFTHR mutation, also a genetic disorder called annexin. It is something like APL syndrome. I have to take heparin injections. At the age of 30, I had 4 natural pregnancies, which all ended in early miscarriages. What is your advice? Keep trying and say bad luck, or investigate it further diagnostic?
Well, this is really complex. I mean, I'm sorry I cannot cover this in the of today's talk, but by all means, Selma, please send an email, and I will try to individually reply and explore a little bit more your case. I mean,
okay, we can do that.
Do justice if I gave you 1 or 2 minutes in the context of today's talk, but please feel free to email me.
Perfect. I will simply forward the question, okay, Selma, and Dr. Tsakos and his team will definitely get back to you. This definitely needs more. You need to look at it more carefully, I'm sure. So thanks a lot. So we will be finishing for tonight, but as I've mentioned, all the questions that we didn't answer tonight, we will forward them. I'm sure you will have some answers from Dr. Tsakos, right? So thank you so much, everyone, for joining us tonight. Thank you for being patient. And Dr. Tsakos, as always, it's great to have you. And it's been very, very interesting. And of course, it's been very useful, I'm sure. And as you can see, thank yous are coming in as always as well. Any last words you would like to add before we finish, of course?
Thank you so much for listening. Thank you, Caroline, for the amazing initiative. Thank you for all the challenging questions to the audience, and I hope I have helped you a little bit tonight. Keep going, keep being optimistic, and hang in there. And I wish you all the very best. Thank you so much for listening tonight.
Thanks so much indeed. And as you can see, more thank yous. And this is always great to listen to you. I couldn't agree more. Just remember, it has been recorded. You will have a chance to watch this tomorrow. It will be available on our YouTube channel, but also on my IVF Answers website. So go ahead, check this in. And we will be back with Dr. Tsakos, I'm sure, very soon. And also next week, we will talk about non-invasive PGTA, which is something new. So I hope you will be able to join us, sign up, and I will hope to see you next week on Tuesday as well at 7 p.m. of course. Thanks so much. Take care. Have a good evening or day wherever you are. Take care. Bye.
Bye-bye. Bye.